Okay, wonderful. Well, it's so good to see everybody. I guess I'll go ahead and start introducing people. I know we've still got people kind of joining on, so I'll kind of continue to let people join in, but I wanted to say thank you for joining us on what here is a beautiful Sunday. I call it afternoon because the sun is still out. So thank you so much for joining us on this beautiful Sunday afternoon. I want to go ahead and uh, share some slides with y'all if I could. And let's see. Here we go. All right, it's just being a little testy for me now. Okay. Now, wonderful. I think everyone should be able to see that. So thank you so much for joining what is our first kind of meeting for the new academic year as we think of it, for the Alabama chapter of the Voice Foundation. So we have a fairly regular schedule of programs that we like to put out, usually on Zoom, so they are open to anyone. We also encourage people to join the Voice Foundation, and we can provide a few more bits of information about that. But first, I just want to kind of introduce our leadership team. So we have I think we have everyone on with us. We have we have Edie Hapner, who is our past president. Elizabeth Benson, who is our current president, who's done some really, really beautiful work, the two of them. Valeria Chetta, who is our president-elect. I am Molly, I'm the membership director, and we have Levada Harrison, who is our secretary-treasurer, who is also on. Here we go. So who are we? A group of us got together in 2020 when we were stuck at home and had nothing else to do and wanted to kind of meet the rest of the people in our state. And I'd have to say that Edie Hapner was a big proponent of this, wanting to meet people when she had moved to our dear state of Alabama. So we have a large group of speech and language pathologists, singing and voice trainers, we have laryngologists, we have actors, we have teachers, we have professional singers. And then we have a larger community of people that come and join our meetings from all over the country. We have New Zealand, we have Canada, and many places in Europe as well. So obviously we welcome everyone. So if you'd like to kind of get involved or follow us on social media, you can take a little snapshot of this with your phone. You can also get in touch with us to join our email list. I try not to spam everyone too much, except for about the week before all of our meetings, because we have a few procrastinators in the group who like that kind of final official reminder that the meeting is starting. We also want to encourage, if you'd like to be a little more active in your participation, to kind of get in and join our team. So you can work with with Valerie next year, who I'm looking forward to seeing what she can do when she takes over. So if you're interested, please get in touch with us through our email or through one of our board members, or you can send an email out to us as well. So really quickly, before I introduce our wonderful presenters, I'd just like you to go ahead and add the next meeting to your calendar, October 19th at 5 p.m. Central Standard Time. We'll have Dr. Molly Perryman, who is an MD laryngologist at the UAB Voice Center, and she will be kind of sharing with us, you know what, actually I won't tell you what she's going to be sharing because I'd like for you to join as much as you can. So please put that on your calendars, and if you would like to be added to our email list so you can get some of those email reminders, then I can also do that. So the whole reason y'all are all here today is to see our wonderful presenters. So we're going to talk about rehabilitating the artist, and we're going to talk about this team effort between the clinic and the voice studio, this kind of no man's land that I feel like a lot of SLPs and voice teachers get a little confused about. And so I'm really looking forward to seeing what Adam and Stephannie have to say about this. So we'd really like to welcome first Adam Lloyd. who's an associate professor and deputy chief of speech pathology at the University of Miami Miller School of Medicine, with a secondary appointment in vocal performance at the Frost School of Music. What I will do is instead of reading their full bios, I will actually attach them to our chat so you can read them while we're learning a little bit today. But he is a recognized vocalist through the PAVA RV, and he is an active contributor to national and international conferences. So thank you, Adam, so much for being here. We're looking forward to it. We'd also like to welcome Stephannie Moore, who is a voice and audition coach with students performing across the US, UK, Europe, and Asia, as well as many of the people that we have online with us today. She is on faculty at Lynn University within the Department of Drama and has taught in both musical theater and classical voice programs at the Florida International University and the University of Miami. I'd like to also showcase that she's also a recognized vocalist through PAVA, and she works closely with clinicians from the University of Miami to help vocalists return to that kind of what we like to say as a vocalist, sweet spot in our singing once we've lost it for a little bit. So thank you also for being with us, Stephannie. So without further ado, I'd like to send it over to you once I stop sharing my screen. So thank you so much, Adam and Stephannie, for being with us today.
All right. Can everybody hear me okay? Okay,
And
excellent.
actually, Adam, really quickly, I'm going to interject to say that
Sure.
we would like to welcome your questions kind of throughout the presentation. So if there's a question that comes to you, you can gently interrupt, find a silent spot. You can send a chat over to Adam or Stephannie or myself, or you can raise your hand through the little raise your hand thing on Zoom, which is lovely. So now, without further ado.
All right, perfect. Well, first of all, I just want to give a big thank you to Dr. Stephannie Moore for being willing to be my partner in crime, not just today, but for many, many years now. And it's been a pleasure to work with you and to work with multiple different singers that have gone through this process.
Yeah,
So,
thank you, Adam, and also thank you to Dr. Elizabeth Ann Benson, one of our friends and colleagues who invited us to be with all of you today.
yeah, and there's so many wonderful, amazing voice people in Alabama. And so thank you to all of our colleagues for being here today, making us feel just a little bit more nervous. But Edie, I'm looking right at you. Oh, I'm just kidding. You always make me feel so good. So thank you for being here as well. All right, so let's get on with it. So, Steph, you want to introduce yourself? Tell us a little bit about your journey.
Hi, everyone. I'm so happy to be here. My journey in the world of kind of singing voice rehab began for me many, many years ago when I was in high school and had my own vocal fold issues back in the day when I was getting ready for my BFA musical theater auditions. And it's been an area I've been super interested in forever. Sorry about the dogs who are wrestling in the background if you hear them. And I started working with singers who were looking for help with their voices and recovery over 25 years ago. Oh, dogs, shh, they're wrestling over a bed. Over 25 years ago, before I even went back and did a master's and a doctorate, and it was an area that always really fascinated me. I did go back to school kind of later in life and finished my doctorate in 2019, and that's where I got to meet Adam. And he was actually the person who taught me my voice disorders course and my DMA work. And it was really fantastic to kind of finally have a lot of the names for the science that I had sort of intuited when working with voices, but it really helped me approach it from a whole different direction. These days, I am primarily working with musical theater singers these days, and it's really important for me to be able to encourage them in healthy singing before they might encounter an injury, as well as help them through those times in a myriad of ways. So that's where I am now.
Awesome. Well,
Yes.
a little bit about my journey. I finished an undergrad and master's degree in vocal performance and then had a vocal crisis. And it was a really, really scary time for me as a singer. And, my identity was wrapped up in me and my singing voice as well. And I decided to, I was always interested in vocal pedagogy and had been teaching for a couple of years at that point, and found my way to rehabilitation for my own voice, and then thought, oh my gosh, this is an amazing field that I should learn more about. So it brought me to the field of speech pathology. And when I entered the field, I thought I'm only going to work with singers because that is going to be my focus and my mission in life. And interestingly enough, I found so many more populations within the field of upper airway and voice and dysphagia that I just was fascinated about with the anatomy. And like Stephannie was saying, I love teaching and I love being a part of other people's learning process. So that's sort of been my journey up to this point. This middle picture is of me and Stephannie last year at PAVA. What show were we at, Stephannie?
Noise is off.
Noise is off. That's right. Yeah. It was a great show. All right. So being a singer with a voice problem is a crisis. It is a big deal. It not only can affect, if you're in an academic environment, your academic success, but like I mentioned, it can affect your emotions and your self-esteem, your livelihood, your reputation, and other potential, income and things like that in the future. Stephannie, you want to add to this?
Sure. I wanted to add that one of the major areas we could still do more work on as voice professionals is around the stigma that comes with voice injury or voice dysfunction. And two instances I want to share with you briefly. One with a student that I was working with in a BFA program, the stigma around the idea that she might have a voice injury kept her from seeking help for a very long time because she kept saying, I don't want to know. I don't want to know. I don't want to know. I don't want to hear the N word, right? The nodule word. And interestingly enough, it's not just the students, it's not just younger singers who have this stigma and fear around it, but I have even had fellow faculty say to me, actually, a program I was affiliated with in the past, say to me, we don't want to publicize that we have a connection to a laryngology clinic because then people will think we're giving them voice injuries. Um, and so we really need to educate people better about the fact that if you use muscles, they are going to sometimes have problems, and that comes with all muscles of the body. So I wanted to mention that because, as Adam was saying, yes, obviously the concern about professional reputation is a big deal, but also the fear of not getting hired because people might think of you as a liability if you're presenting with any kind of history that people know about. Next slide. So, as all of us, I assume, are well aware of, and I don't need to say much about it, singing can be a very core piece of self esteem for those of us who are voice users. And some of us have been singing for our entire lives, and the loss of a healthy instrument can be extremely disorienting. For many singing artists, without realizing it, they have kind of simultaneously developed skill along with an unconscious sense of self-worth. And so when one of those things is impacted, like ability changes, that self-worth sensation can also change. And it often catches people really kind of off guard. This, of course, is going to vary depending on the age, depending on what kind of voice user you are, whether you're an amateur, a developing singer, a professional singer. And so, one of the things that I do when I'm working with younger singers is that I try and, without setting them up for planning for problems, I do like to encourage them to always keep all the doors in front of them open and to say to them, what if you weren't a singer? Do you have other interests? Because as we all know, a career as a singer or someone working in the singing field can be very difficult. And I do like to encourage people to explore all the various parts of themselves that aren't just identified with an identity as a singer, so that if anything should happen to happen to that part of their identity, they're not going to maybe feel as much of an intense fear and loss around it. So just encouraging singers to always keep the doors open to other areas of enjoyment in the performing arts, outside of the performing arts, whatever that may be, to encourage them that they are so much more than their abilities. Next slide. I used to be able to. So sometimes when a loss of skill or ability happens due to some sort of vocal dysfunction, we discover these new experiences in kind of little bits at a time. So maybe it's working on a particular technique, singing technique, or returning to exercises we've been able to do in the past, or reviewing old repertoire. It really is a non-linear process when people are starting to kind of put the pieces back together again. And so some of these discoveries about the new state of their instrument will continue to unfold over time. Next slide.
So who recognizes there's a problem? Sometimes it's the singer themselves. Sometimes it's the voice teacher that works with that singer very frequently, but it might be other people too. It might be somebody like a friend saying, your voice sounds weird today, or your voice has been sounding really tired or hoarse. What's going on? Family members, friends, or what a singer doesn't want to have happen is their director or their manager tells them, hey, what's going on with your voice? It doesn't sound right, right? That's a very stressful situation. So who is making these referrals, and who is telling the singer that there's a voice problem? All right, so a comprehensive voice evaluation is going to include different things depending on where you go, but I would say most people would probably agree that there's going to be a very in-depth history of the singer's symptoms and their medical history. Talk about what medications, including herbal medications. There's going to be some sort of physical examination that a physician is going to do. There's going to be a visualization of their vocal folds, hopefully with a video stroboscopy. There's going to be some sort of aerodynamic assessment on how the vocal folds are interacting with the airflow. There's going to be some sort of acoustic analysis of the sound of the voice. And then for many, many years, as we've all been doing, is we're going to be judging the way that the voice sounds based off of our expert ears, right? And that is certainly not unique to the voice medical evaluation. So I want to take a second to talk a little bit about the difference between seeing, and there's nothing against a general ENT, but the difference between seeing a general ENT who sees sinuses and ears and all sorts of things in their career is that they're not going to have the same type of tools and have the same type of in-depth analysis of the voice that a singer needs in order to really understand what's going on with the voice problem. And this is an AI generated image on the left there. As you can see, there's probably not a flexible scope that actually looks like that. I'm not quite sure what that extra tube is coming off of there, but you know, if somebody comes at you with something that looks like that, get out of the office. So we want to send our singers to a voice care team. And typically that's going to have at least two different members, types of voice professionals in it. It's going to have a laryngologist and a voice specialized speech pathologist, and hopefully at least collaborative with a vocal pedagogue that they can send them to and collaborate with as well. And multiple different other team members. Stephannie, can you think of any other team members we should add to that list that are very important?
Well, depending on the circumstance, let's say we're working with a university student, we may need to bring other faculty on board with the student's permission to assess whether it's going to impact the academics, performance obligations, that sort of thing.
Yeah, very cool. So I do want to take a second, and many of you are probably familiar with this, especially if you're a speech pathologist, but how do we make something that's so very subjective, the way that we describe how someone sounds, how do we make something that is so subjective more objective, right? Well, one of the ways that we do that in speech pathology is we use a tool called the consensus auditory perceptual evaluation of voice. And it allows us to break down different variables of how we perceive the voice and judge their severity of those different qualities. So let's give an example of how to do this. I'm going to play an example. I want you to listen to the quality of voice. And of these 5 variables or 6 variables that you see here, overall severity, roughness, breathiness, strain, pitch, and loudness. I want you to tell me what sticks out to you the most, and I want you to give it a score between 0 and 100. Okay, let's do that. Listen.
We were away a year ago. The blue spot is on the key again. How hard did he hit him? We eat eggs every Easter. My mama makes lemon jam. Peter will keep at the peak.
Okay, so what variable sticks out the most to you of those 5? You can type it in the chat if you want, or unmute. Got some chat action going here, maybe? Not yet.
I'll say I hear raspiness.
You hear raspiness. Okay, so we're going to put that under the category of roughness just because that's how the Cape V uses it. Yeah, okay. So roughness. So now give me a score from 0 to 100. Whatever your interpretation is, there's no wrong answer.
Let me say 70, but I don't know what the
So Molly, there's no right answer, because what you're going to do is you're going to judge your clinical opinion based off of your clinical opinion at another date.
Okay.
But just to give you the right answer, which is not the right answer, which is my answer. This is approximately what I said. So I agreed with you, 70. Look at that. Great minds think alike. Wow. Look at us go. So there's different other variables that we hear in severities in the voice. And again, I'm basing my opinion right now. And then when I listen to that voice after I do voice therapy, I'm going to do the same thing again to measure some progress.
Dr. Lloyd, could you move the chat box? It's just overlaid on the image.
The chat box
delete it. It's just a black box, but yeah, it's blocking our view. Thank you.
There we go. Thank you so much. I'm glad there wasn't nothing incriminating in the chat that you could see. All right, so I just wanted to give you guys, for those of you who have not seen the Cape V before, just an idea of how we do that from a perceptual evaluation standpoint. All right, so again, most of you are probably familiar with endoscopy and how this works, but my colleague Maria, who I don't know if she's on here tonight, she may not be, but she did 2 different videos, one of rigid and one with flex, side by side, an exterior and an interior view. So here is the rigid scope.
All right, so we're going to take a look here. I'm going to prop you up.
I think this helps to demystify kind of what it looks like. I like to show students this. It's not so scary. It's very easy to do. Doesn't hurt.
Through the mouth, I'm going to have you lean forward like you're at a baseball game, chin way up in the air, and the whole time I want you to breathe through your mouth. I'm going to have you stick your tongue out and say E, no vibrato, mezzo piano. I'll let you know when to start. All right, so stick your tongue out.
That's our previous fellow, Eitan Kadar and Maria Merliacic, one of our speech pathologists. So you're about to see a side-by-side view there now.
All right, now side, move it high. Say E. Say E.
All right, so you kind of get the idea of what that looks like. So now we'll look at a view from a flexible scope. So this patient may look familiar to you.
First, I'm going to have you, the whole exam, hold this microphone to your neck, right here, and say E.
E.
Perfect. This is going to go through your right nostril. You've already been sprayed with lidocaine and Afrin.
So she's saying, if you can't hear it, we spray with a little bit of mixture of lidocaine and Afrin to numb the sensation and to open up the nasal passages a little bit to make it more comfortable.
Gently through your nose.
And as a side note, I learned endoscopy from Edie Hapner when she was at Emory.
But I'm sure you're so much better than me.
Oh, I highly doubt that. And here's our side-by-side view. I'm a very mucusy person. I have allergies and on the regular, so my vocal folds never look
Take a big
pristine,
sniff in
but there they are in all their glory.
and swallow.
What's nice about the flexible scope is that you can have singers do
Say
different tasks, like
E.
sing, where you can't really do that with a rigid scope. You can, it's just they can only do it
High
on
pitch.
as opposed to the actual words, the vowels.
Clear your throat. High pitch again. And you pitch glide from low to high. E.
Well, there is more to this video, but I think you all get the point there. Any questions about the difference between rigid and flex? Everyone here probably is aware of that, or
Adam, you do
yeah.
have a question in the chat.
Oh, sure, please. Why was loud marked as increased? Good question, Sabrina. So you're talking about on the Cape V, and I think that that was just my impression of the way that that person's voice sounded. But honestly, from a recording, it's almost impossible to really judge loudness very fairly unless you know exactly what the mouth to microphone distance was and know what a comparison voice would sound like. So that is a great question. Yeah. All right, so just a couple of things about medical diagnosis. We have to rely on our medical physicians, our medical doctor physicians in order to assign a medical diagnosis. And in order to have a diagnosis of a voice disorder, you have to have visualization of the vocal folds. That is a very, very important thing. And only a physician is qualified to make that medical diagnosis. Okay. So a medical intervention or recommendations may include voice rest, may include referrals for voice rehabilitation with the speech pathologist, may include referral to voice habilitation or singing voice lessons, pharmacological treatment like PPIs or steroids or something like that. There are many different types of office-based procedures that are being done now in laryngology, and of course, phonosurgery in the operating room is still an option for certain types of pathologies. We like to call it laryngeal rehabilitation, and because I feel like instead of voice therapy, it's a little bit more of a catch-all that includes the larynx, including hypersensitivity and other things that we do for people who have like things like muscle tension dysphagia. And so, voice therapy, laryngeal rehabilitation can consist of a lot of different types of things. There's not one exercise that fits all because everyone is so very unique in their presentation that not everyone is going to be appropriate for resonant voice or vocal function exercises. So we have to take that into consideration when we're seeing our individual patients, what their individual needs are going to be. With that said, here are some of the more techniques that you're probably going to hear about, or if you have students that are going to be in voice therapy that they may talk about, including vocal hygiene. We all use semi-occluded vocal tract exercises. We've been using those in singing training for many, many years. We do flow phonation, focusing on sensations of airflow. Resonant voice focuses on sensations of vibration. We have the inventor of Forte here with us tonight. We also do other protocols for neurologically based voice disorders like LSVT and Speak Out. And we also do a multitude of laryngeal manual therapies like laryngeal massage, circumlaryngeal massage and reposturing, respiratory muscle strength training, whether it's inspiratory or expiratory, as well as conversation training therapy. I'm not going to get into the nitty-gritty of these tonight, but we will mention some of these in the context of some of the cases that we're going to be talking about. So Stephannie asked me to answer this question: what determines readiness to transfer to the studio? And there is not one right answer here, in my opinion, and I'm sure that we could all debate this for many, many years to come and will continue to debate this. I describe it as I like to work in a rehabilitative manner until the patient feels like they're no longer exacerbating their symptoms as they use their voice. and their anatomy continues to respond favorably to the rehabilitation plan. Voice rehabilitation and habilitation share a lot of the same exercises as you will hear Steph and I both talk about tonight. And so having rehabilitation and having habilitation sometimes is going to overlap. In fact, I think that is a very successful model, is having both at the same time as the person transitions. How'd I do, Stephannie?
Loved it.
Okay.
Should we keep going?
Yeah, go for it.
Okay, great. So obviously there are many different scenarios that might play out depending on the team and depending on the needs of the patient.
I'm so
But
sorry to interrupt. The overlay is still showing. I just want to make sure we don't miss anything on your slides. Adam, there's like a little bar at the top. It might be the chat or some notification. Thank you.
They gone?
Gone. Thank you.
Perfect. Thank you.
next slide, Adam, please. So when I am working with a singer who seems to be exhibiting vocal changes or vocal issues that don't seem necessarily related to just singing technique, I don't hesitate to reach out to Adam and his team, and they're so amazing. I've worked with Adam at when I've been at 3 different universities, and I always reach out immediately to Adam and say, can you see this student? They're a singer. This is the circumstance. Sometimes they're a professional, sometimes it's a university singer. And generally, his team will see my singers within a week to 10 days, which I think is unheard of in terms of if someone tried to reach out to a specialty clinic on their own. So I am always so grateful for that. And the singer then goes ahead, gives permission for them to speak with me so that we can all kind of talk. And one of the important features of that is that once the singer has had the medical assessment, I like to connect with the SLP in my own meeting just to get their recap of what took place during that appointment. Because oftentimes I'll see the student and I'll have all kinds of questions, and they either didn't understand necessarily all the medical lingo, which why would they? Or the other thing is it can be a very emotional experience for them, and they maybe just have kind of blanked out what some of the recommendations were, or some of the the outcomes, or some of the the obstacles or whatever. And so I like to have that meeting, and I think unfortunately we don't do as great of a job at this as we could, mostly because all of our lives are so busy, our schedules are so tricky. But I think it's an important thing to make sure that there's always this conversation going. And as this singer is continuing to see both of the professionals, then there is every so often a check-in. Next slide, please. So there could be many topics to explore in that initial meeting and in the ongoing meetings. These are just a few of them. For instance, what determines, is the client going to continue to work with the SLP, or do they get to graduate onto just the voice studio? What will be the ongoing return to the clinic? What kind of strategies will both of the professionals be using in tandem with the student? And will the SLP and the voice teacher need to have ongoing communication? And that's obviously going to change case to case. I don't tend to have direct communication with the laryngologists, but I do know the ones in Adam's clinic, and I would feel very comfortable reaching out to them. But generally, it's worked out well for me to just work directly with the various SLPs in the clinic. So that model seems to be working. Next slide, please. The great balancing act. So once we get someone back to the beginning stages of singing again, it can really unleash a whole range of emotions. And on the left side, well, actually it's the left side of your screen. You can see the things that are exciting, relief, I'm back to singing, I'm feeling confident again, I'm trusting that I'm well. That's a big one. And then on the other side, we have a lot of times things like fear of re-injury, self-doubt. Maybe if this is a circumstance where a singer has come to an injury based on maybe a maladaptive kind of habit, or some kind of coming into contact with, I don't know, phonotrauma of some sort, whatever the case is, they will doubt their own ability often to use their voice again. And another piece of that is just unfamiliar sensations. I had one student that I worked with who had focal fold nodule surgery, laser surgery. And when she came back, she was in an undergraduate program. And when she came back to her voice lessons, she felt all these different sensations. And it's hard to say if those sensations were legitimate. Hi, can you close the door, please? It's hard to say if those sensations were legitimate, real new sensations, or if they were based in fear and her brain was creating sensations where there wasn't actually a physiological issue. But with every exam that she continued to have, she was getting the information that everything looked perfect. So the fear related to the unfamiliar sensations was probably her largest obstacle in coming back to singing. And in the end, she didn't come back to full performance mode. She graduated and went into education and decided to go more of a teaching route rather than a performance route. And I think that a lot of that was just what happened post-surgery, that she couldn't really adjust to what was perceived to be a new instrument. Next slide. Managing expectations. This is always a little bit of a tricky dance. So along with the pairing of the opposite of the other page, we have this juggling act of being able to stay positive and optimistic, but also recognizing that there is a certain amount of realism that's necessary. And resilience, we are very resilient beings, but there may be aspects of recovering our voices where we may not have the same voice we originally had. I'm thinking of one circumstance where I worked with a professional worship singer who was a university student, and she had all kinds of voice issues. She'd been in the program for a couple of years, and I was surprised, had never been scoped actually before, had never seen a laryngologist. And I was hoping what we would find was something very treatable, but what was found was sulcus, which was scarring, which is really not super changeable once it's really thickened. And so she was not going to find that voice that she was hoping for, and she had a lot of limitations as a result. She is still singing and still doing worship singing primarily, and I think she is comfortable and come to terms with those changes, but we do have to be realistic that not everyone is going to come back to the baseline that they're most familiar and comfortable with. In some cases, I will recognize that a singer goes and finds a therapist who works with people with chronic illness issues or even performance anxiety issues. And another thing that I try to keep in mind is that we have to make sure we don't go too fast. A lot of times singers want to just charge full speed ahead back into their training, and they've potentially lost stamina. And they've potentially lost some of the skill and some of the muscle strengthening, the muscle coordination. And we have to be careful to allow them to be really enthusiastic about it, but also encourage them to be a little bit cautious for a while. Next slide. So we all know, obviously, that habits are very hard to break. But the good news is that we can rewire our brains to sing in new ways and dispose of habits that can be harmful. And we can habituate to physical sensations that may feel new now, but over time we do acclimate, we do adjust to those sensations. And so it's one of the most wonderful things we know about the brain now with neuroplasticity, and that we can change all sorts of things we didn't used to think we could change. Next slide, please, Adam. So in the voice studio, one of the first things that we're going to do is take a look at the habits that have been non-beneficial. Now, in cases, for instance, if someone has an injury related to surgery and intubation, which is one of the cases that we're going to talk about today, that is not necessarily based on a singer's non-beneficial singing habit. And a lot of the habits that they need to develop, the better habits, they will already have been working on in, what is the word you're using now? It's speech therapy now, laryngeal rehabilitation, Adam?
Yeah, that's what we said, yeah.
Okay, great. so some of these habits that we're going to look at is the person using breath efficiently. What is subglottal pressure like? How high is the larynx sitting? What kind of tension do they have in the tongue or in the neck, or stress going on in their lives? Things like that. Obviously, they're the same things we're going to be talking about in those therapy sessions, but now we're going to address them in a more nuanced way, using specific pitches and sustained sound. And we may find that we have issues with these parts of the body that we didn't necessarily have in the speech rehabilitation. And so now we have to figure out, oh, the person when they were singing for all of these years never realized that they tended to kind of turn their head and look over the right shoulder when they were singing, because they weren't doing it when they were speaking, and it wasn't present in the speech language pathology office. But when they go to sing, we can oftentimes uncover habits that even weren't discussed or discovered in the therapy session. Next slide, please. So I made this funny little graphic, thank you ChatGPT, because I often tell new singers, and this is not just singers that are in some kind of voice recovery, but all of my singers, that when we're learning to sing, I think of that ability to perceive the singing voice as like we are developing an additional sense organ, right? We have touch and taste and smell and all of those things. And we have, in addition, this ability to now perceive our instrument. And by instrument, I really mean, obviously, we don't have sensory nerves to feel on the vocal folds themselves, but we have a lot of sensory information throughout the laryngeal area, throughout the face and the jaw, and in the muscles, and throughout the whole kind of thoracic area. And so it's like we are learning to perceive sensations we didn't necessarily know to look for before. And I think it's very exciting. And I think a lot of voice teachers will know this common thing when singers are singing with them in the beginning, and the singers are like, gosh, I feel like I'm so bad now. I didn't know how bad I was at singing. And it's not that they were bad at singing, it's that they didn't have this special sense honed to notice what was happening before in the way that they do now. Next slide, please, Adam. And I think I'm passing, well, I'll say one more thing about this, staying in the present. So frustration, fear, worry about the future, all of these emotions show up, and they come and they go in the process. And adding to the fact that they just arise, they often impact, obviously, like the tension that we're feeling in our necks, because we all know how emotions impact our whole speech centers of our body. And so reminding students to stay in the present, reminding the singers to be with this moment and going for the sensation of this moment, and trying as much as possible to be mindful. And I even do prescribe some actual mindfulness exercises for my students, and do some in the studio, because anxiety is always based on the future worry or the past worry, right? Reflection on the past or fear of the future. And it can be very counterproductive to the habilitation process and rehabilitation process. So as much as I can, I introduce ideas of mindfulness. And for some students, it's a brand new concept. Sometimes it's just basic breathing that we work on, just to stay focused on the present, try not to get caught up in the emotional turmoil that may come and go. Okay, and now I'm passing this back to Adam for a bit.
All right. So we are really excited to have prepared 3 cases tonight. We may only get through 2. I think we're doing pretty good on time here, so maybe we'll get to the 3rd one. We are very honored to have, I think, one of the 3 people that we're going to present on today who's actually with us tonight. So we'll have Kristen when we present your case, Kristen. We would love for you to unmute at the end and have us converse with you a little bit about your experience. But this first case represents a 69-year-old female who presented to us at the time, and she was complaining of voice loss, weak and low volume, and a raspy vocal quality. This happened immediately following a upper lobe resection for lung cancer, where she felt like the intubation was traumatic for her. She additionally, other than having voice problems, she was also coughing, with liquids and how to have some increased effort to swallow. We're not going to talk about her dysphagia tonight necessarily. We're going to focus on the voice, but she did improve over time with her dysphagia symptoms as well. She did have some symptoms of reflux previously, but was well controlled on a proton pump inhibitor, and she loves singing. History of asthma and GERD as well. So social history, she did have a distant history of smoking. She drank about 2 alcoholic beverages per week, 2 cups of caffeine per week, and very good with water, which I wish all of our patients and students would do. We did do a Cape V analysis on her, and remember 100 is the most severe. The overall severity was 85 out of 100 for the clinician who rated her that day, which is pretty severe, right? So the variables that we were hearing in her voice were rough, breathy, strained, and soft, which correlates with the symptoms that she was experiencing. Her maximum phonation time was only 2 seconds, which is a very short amount of time and definitely out of the range that is normal. Her fundamental frequency there is below average, and her Kestrel spectral indexes of dysphonia, which is a calculation of acoustic measure, is very dysphonic. Above 24.3 is a dysphonic rating, and she's way above that. She has a very high score for her voice handicap index 10 and her singing voice handicap index 10. So a pretty significant severe perception from the sound of her voice and the way that her voice sounds to her as well. So here's her original video stroboscopy, and let's see if you can see which vocal fold is problematic. It's very hard to hear. The audio is not the best, and also this patient was also just very soft. So I think the thing that we can see very clearly here is that this left vocal fold doesn't appear to be moving, right? And there's a big gap between the vocal folds when the vocal folds are at their most adducted state. So this patient was diagnosed with a left vocal fold paralysis. And these pictures here on the screen this is my colleague David Rosso. He's the laryngologist, and myself and Maria were participated in various evaluations that this patient had over time. This patient had multiple different types of treatments with our institution and our clinic. She first had a gel injection with a Prolarin gel substance, which is a temporary filler material, and this was on her first visit with us. And then 3 months later, she did have some improvement in her voice, but wanted a longer lasting result. So she had a more thicker material, longer lasting material called Prolarin and Plus. Then after that, she had a series of voice therapy sessions, which we'll talk about in a minute. And then about 18 months from the first time that she saw us, she ended up having a medialization thyroplasty, where you basically put in a material into the outer part of the vocal fold itself and push over the vocal fold so that it meets the other side better. And then she also had an adduction arytenoid plexy, where you take the arytenoid and you move it closer towards the other one. And this is the post-treatment video stroboscopy. And pay attention not only about how she sounds now, but also how the vocal folds are touching together and vibrating. So they actually have contact and vibration now. She doesn't have that compensation tension squeeze around the vocal folds anymore as she did before when she was really trying to get sound to come out. Okay, so still kind of asymmetric vibration, but better closure and a little bit of an anterior gap there, but certainly a lot better than there was before. So that's what we're moving on from now into therapy. So this patient actually was seen primarily by my colleague Jenny Lee Diaz, who works at Cleveland Clinic, Florida. And after an injection, it's often appropriate to start with vocal hygiene, making sure the person is not overusing their voice and allowing the tissues to heal after an injection, after a surgery. So that's where the low impact voicing exercises come into play as well. And building up with finding the right balance with airflow and glottic closure with the SOVT exercises and vocal function exercises, and reducing any compensatory tension with the laryngeal manual therapy. She also saw my colleague Christine Martin for continued voice therapy after surgery, and she did vocal function exercises as well as straw phonation. All right, moving on. Stephannie.
So unfortunately, this singer patient was supposed to be with us today, but now has a COVID diagnosis this afternoon. And so she was unable to be here, but she wanted to say, she really wanted to be here to talk about how amazed she has been at what the kind of progress and outcome has been through all of this team collaboration. When I first met her, well, she is not a professional singer, but she is someone who's been singing her whole life, every style of music. And as she described to me once, if she couldn't sing, she didn't want to be alive. And so after the surgery, after working with the speech pathologists for a while, she came in my direction. And when I first met her in our very first lesson, she only had a range of about a perfect fifth, which is a very small amount of notes for a singer. And they were all really low in her range, much lower than they used to be in her range. And basically, her voice would sort of disappear at E4, which we know at E4 there tends to be a registration event in most singing voices. And she had a tremendous amount of neck tension. And it's interesting, Adam, when I heard you say that she only could sustain a tone for 2 seconds, she could do a couple more than two at her first lesson, but it wasn't very much. But this last lesson, this last week, she actually, at one point, she figured out something new and she made out this super loud sound and must have held it for like 17 seconds. So she was, the tears are coming out of her eyes. This has been a very emotional process for her. She also now, at this last lesson, we went just over 2 octaves in terms of actual pitch. So we are working on connected melodic phrases. She has a vibrato coming in now that was absent for a very long time. It's still her head voice is extremely quiet and not very strong. So we're working very hard to coordinate up there. And her tone is becoming much, much more consistent. So I mentioned here disparity of speech versus singing because she was sort of released from her therapy sessions because they felt like her speech was functioning very well. But when it came to making a singing sound, at first it was like she had no idea how to make that happen. So it's been a complete retraining for her. And in just a couple of months, she's made tremendous progress. Next slide. Some of the things that have really worked for us is, first of all the things to work on the resonance, all the humming sounds, all of the buzzing sensations are really important for her, especially as we develop the stuff that's above E4. She does great when we use the closed vowels of oo and e, and we do vowel morphing exercises. So if she can get a nice clear oo sound, we will transition into, on one sustained pitch, into other vowel shapes, trying to figure out how to minimize shape changes, trying to figure out how we can keep the sensations similar. And one of my favorite little techniques for the people who tend to be a little bit more chest dominant in their singing is what I call the beautiful baby, which she laughs every time we do it. And it's that I have them say, "Oh, what a beautiful baby." And it's funny, my little Zoom came up, said playing music. No, I'm not playing music. But that sound for her, that conversation, oh, what a beautiful baby, seems to remind her how to keep her voice feeling more resonant that way. And we then can use the beautiful baby sensation and the beautiful baby pitches and sounds onto actually a lyric or some kind of sustained melodic sound. So I think we've had good success. We have a ways to go, but she's very happy about her progress. And yes, I think I covered all of these things. Yes, connection and E4 and that passaggio there is definitely improving. For the first couple lessons, she couldn't make any sound in about, I don't know, maybe chromatically a minor third. There was like just no sound at all right around E4. Next slide. And she's not here, so we're not going to ask her any questions.
All right. So, Kristen, thank you so much for being with us tonight.
I'm glad to be here.
Such a pleasure to have you with us. And we're going to present your case. And you feel free, if you have questions or want to correct us, feel free to unmute and let us know.
Can you hear me?
Yeah.
Okay. All right, good.
Yeah, we can hear you. We really
Okay.
appreciate you being here tonight to share your perspective.
Certainly.
So Kristen was actually a referral from a laryngologist at Emory, Dr. Heron. And actually, Kristen, you and I met together one time in the beginning. Yep. And you had a diagnosis of muscle tension dysphonia. And Kristen was complaining of decreased high pitch range, hoarseness, tightness and strain in the neck muscles, as well as vocal fatigue for the previous 2 years. And she was working with some of her physicians as for a possible autoimmune diagnosis at that time. It wasn't clear. And Kristen is a music minister and previously a teacher. Her social history included never a smoker, 1 cup of caffeine a day, pretty good water intake. And really, the success of Kristen's voice rehabilitation is owed to Dr. Julia Gerhard, who's not here tonight, but which is to, say congratulations to you, Kristen. It was wonderful working with you. Just to summarize Julia's wonderful work, you and Julia together, your wonderful work. Julia did a technique called yawn sigh stretches and some laryngeal massage to try to reduce hyperfunction in the neck muscles. She also did a series of protocols to try to improve balance between airflow and vibration with resonant voice, did some semi-occluded vocal tract exercises where she started off with sustained sounds, went into vocal glides, then also tried to touch and carry over into some of the singing scales, and then slowly transitioned Kristen back into singing voice lessons with Dr. Stephannie Moore. So I am going to work backward just a little bit because at that point, once she had 14 sessions with Julia, she actually came back in for one more evaluation with us in Miami. And at that point, her speaking voice was pretty darn good. She sounded like, it was maybe a 10, intermittent symptoms of strain and low pitch. She had a maximum phonation time near 9 seconds, which is still a little under what we typically would want to see, but not too bad. Her fundamental frequency was in normal limits. Her CCC-D was also within normal limits, but yet she still had a very high perceptual quality of life measures out of the range of normal for her voice handicap index and her singing voice handicap index. So this is the video stroboscopy that we performed on Kristen.
Go E, E, E,
E, E, E.
And at first glance, you may be thinking, does she have a paralysis?
high pitch. Sing out. Good. Do that
But if
again.
you
Put out.
look longer, there we go. It's starting to move again.
Beautiful. And now low pitch. He.
There's that movement. So she
Good,
gets
do it again.
complete glottic closure for the most part, maybe a slight glottic gap anteriorly.
We were away
Some
a year ago.
asymmetry of
We were
vibration,
away a year ago.
but her speaking voice sounds pretty good there.
First line of happy birthday.
Happy birthday to you.
There we go. Nice. You didn't know you were going to be singing tonight, did you? All right. So, our laryngologist thought the anatomy looked pretty good. Thought there was some minimal dysphonia, mostly of inconsistency and reduced stamina, and we felt like she would be better served in a voice habilitative with a professional at this point. So we referred her to Dr. Stephannie Moore.
So, Kristen, I'm so happy to see you, by the way. It's been
too.
And I'm gonna ask you to chime in a second because I'm gonna talk about something you know more about than I do. But first of all, when I first met Kristen, what I would say was that her phonation felt very grippy to me. There seemed to be like the only way she was able to get sound out by was a lot of squeezing. And there was some lung weakness there. The tone was somewhat gravelly and rough. She was extremely weak through up to or I'm not sure why I said through, extremely weak above E4. So she had a lot of power in the bottom part of her range, but it was much less power than she was used to. And her high notes, as she reminded me, were completely absent at the beginning. And there was also a lot of shakiness on her sustained tones, and it impacted her vibrato as well. It was the vibrato was a little bit unstable. The oscillation was not kind of continuous. Next slide, please. And Kristen, here is a part that I'm hoping you'll tell us a little more about. So while we were working together, I believe that's when you got your new diagnoses. Is that right, Kristen?
That's right.
Yeah. So I wasn't familiar with these two diagnoses. So I don't know if, Kristen, you're willing to share a little bit about that and how you feel that was actually contributing to the MTD.
I was diagnosed last December, I guess, maybe November. I had started getting really sick, just not feeling well. I had been, dealing with the voice issues. And I still don't know for sure if this contributed to my voice issues, but I'm 99% pretty sure now, just because of over time I've been working, and there's things that it's just hard for me to do that should not be hard. Going into my residence is hard. I have to work on it every day, really pressing. So basically the crest between the two diseases, the crest is the worst one. Basically what it does is it causes my organs and my skin to cause calcinosis. Everything hardens, stiffens. I have to do a lot of vocal exercises every day to keep it from being stiff feeling. Some days are better than others. Sunday mornings, I do a lot with being a worship leader. I probably vocalize very soft for probably an hour to an hour and a half. But I have to do a lot of movements in my body. I am on a certain diet, anti-inflammatory diet, that has helped me a lot. I've gotten a lot better since last year. I've come a long way, but it's been a process. I am at UAB now. I see them once a month. I'm on hydroxychloroquine, which has helped me a lot. Kind of settle down my antibodies and the anti-inflammatory diet too. But I really feel like, and the crest causes a lot of esophagus issues. I have gastroparesis from that, which causes a lot of reflux. So after learning about and getting diagnosed and learning about all this, I thought, okay, this is starting to make some sense now. So, of course, I did have some MTD, but I still feel like the diseases caused some of that to, if not all of it, to just because I was forcing. I had lung issues. My lungs have gotten better. So I was having to force everything. But it was such a gradual thing that I wasn't able to, and I wasn't diagnosed. But it was such a gradual thing that I didn't know what was going on. But over time, everything has started making more sense to me. And I've been able to work around. I had to stop seeing Dr. Stephannie. I loved her so much. I want to pick up again, but I had so many doctor's appointments going on. I was just completely overwhelmed, them trying to diagnose, but doing a lot better. So, but it is a process of singing, especially being a worship leader and being over. I've got a big worship team, got live music, to do a lot of speaking early in the mornings when I get there, a lot of singing. And some Sundays I may be doing anywhere from 12 to 15 songs if we have services that night. So it can be a lot. It's hard on me. So I have to be careful with my, I've always been a hard singer. And I've realized I can't push myself. I just have to, take it easy when I sing. But overall, I'm doing much better. And it's because of Dr. Stephannie. She's given me so many, and I use them every day, so many different techniques, so many different ones. And I use them every single day. The straw is a big one, especially on Sunday mornings. If I've had to do a lot of speaking, I have my straw right there. Ooh, I mean, there's so many. There's just so many. I'm constantly thinking of them as I'm vocalizing in the mornings. But I'm very grateful to Dr. Stephannie. I don't know what I would have done without her. I wouldn't be this far along, I know. But and there's some Sundays where people don't even realize I have vocal issues anymore. And I'm thinking, how could you not? But I guess I can.
Recording if you were going to play in a minute.
But she's been a godsend for me, and I want to get back up with her.
I have to interrupt you, Kristen, though, and say that you're one of the most hardworking people I've ever worked with. I can only think of one other person who has been as disciplined as you have been about recovering your voice. And I mean, you have more discipline than I've ever had, And so it's really all the efforts that you've been willing to put into it and done so beautifully with.
And it was a lot of work. You're talking about when I first started with Dr. Julia, I probably was vocalizing, doing any little thing she had me do. And this is no exaggeration, probably 8 to 10 hours a day. I meant I was going to get back. I've sang all over Northwest Florida. I've done sang in a lot of big places. So I was devastated when this happened to me. Both of my parents have vocal majors. They got their degrees in music. So I was brought up from a child. I didn't know anything else. So, so I meant I was going to get back, and I've got a good ways to go. I've come a long way, but just going to keep working.
Thank you. I wanted to mention that one of the things that was really helpful to you that you reminded me of this week was that we worked a lot on sustained vowel sounds with continuous vibrato. Because we had to get that, the airflow, we had to get all of that synchronized, and your vibrato went from being kind of wide and uneven and unbalanced to being much more balanced. And I think when that started happening, the range started to open up more too.
It sure did. Right. Yeah. And it opens up in my resonance better. Everything just opens up when I start, bringing in my vibrato as I'm warming up. Mm-hmm. Right. And humming. A lot of humming really helps me too, because I'm forced to, forced to place it where I need to. So
awesome. Adam, do you want to play the next slide so we can hear her? The other day, she warned me that, to tell you all that she didn't warm up when she did this little clip for me the other day. But you can see she's had a lot of success here, and we got a little clip of her singing here. If we could play that, Adam, please.
From the beginning, you've been unchanging. Age to age you stay, constant you remain. Every mystery, the questions I carry are safe within your will. So I'll trust you even still. I believe you are who you say you are. You do what you say you will do. You'll come through. You are always able. I believe you've already made a way. So I'm running through parted ways straight to you. You are always faithful.
Yay.
Thank you, but it can sound much better than that. But oh goodness.
That's wonderful. Wonderful.
But I have come a long way since Stephannie heard me last with the, moving up in the scale for sure.
Well, I'm so happy to have been a part of it.
Definitely. A major part of it. Major.
We put a slide in here in case anyone had any specific questions for Kristen, or if Kristen felt like there was something we should have added that we didn't add.
I have a question. Kristen, thank you so much for being here. This is really incredible. Really appreciate your generosity in sharing your story. I'm curious, as a worship singer, you're using sound equipment, microphones, monitors. Did you make any changes to the way you listen to yourself or proximity to the microphone or anything else in terms of your interaction with the sound equipment to help yourself go a little easier on your voice when you came back?
My son does the sound in the back. One thing that he does do if I'm singing by myself, he'll put a little bit more, what do you call it? Reverb, I would say. So I'm not having to sing as loud. I do have ear monitors, which has been big because I'm one of those, if I cannot hear myself, of course, I'm going to push a little bit harder to hear. And there's a lot of us singing. So it's going to be a little bit harder for us to sing. And we're about to build on to our church. So our equipment is older. We're waiting to get new equipment. So our monitors are not the best. Ear monitors help a lot. But yes, reverb was a big thing. And trusting myself where I'm not pushing and using my ear monitors. And there was a time where I was up on stage where I was the main voice. And there was a time where I wanted to crawl under the pew because I couldn't. Everybody follows me and they couldn't. But I just had to trust myself and keep working and be patient with myself. And I am not a patient person. So yeah.
Thank you.
Ask a question?
Certainly.
Hi, Kristen. I'm Edie Hafner from here in Birmingham. I wish you a lot of luck with your journey. CREST syndrome is certainly difficult, and it's fascinating to me over the years how many people I've seen with a variety of mixed connective tissue diseases that end up with voice problems. So I'm very curious. Yeah, it's kind of it's fascinating.
I didn't realize that. I'm glad you told me that.
And there's been no actual that I'm aware of study that's linked the two, but I hear it enough, in practice. I wonder if you also have instituted some lifestyle changes that have helped you, because the fatigue, just
Terrible.
overall body fatigue is so huge. The respiratory demands,
Yes.
and especially with using a system that's not the same. So what else have you done besides voice lessons and some voice therapy?
Well, Dr. Stephannie also put me on to the, what is it called? The voice something, the little voice thing you blow in,
Which one? Oh, the respiratory muscle trainer thing.
And I was not able to use that last year. Remember, I told you I could not. Okay, I'm up to almost a level 4 now.
Are you using which one?
Twice a day.
Kristen, which one are you using?
I've got it right here.
Sounds like the breather, maybe.
It does.
Yes, it's the breathing voice.
Oh, the voice. Okay.
That's what I use every day, twice a day. I also am very, very strict with my diet. Very strict.
Heard that.
All anti-inflammatory. I do no dairy, no eggs, no carbs, no sugar. I drink, and even my meats are all grass-fed meats. Of course, if I go to a restaurant, I just try to be careful with the oils if I go to a restaurant. I only use olive oil, avocado oil, coconut. I drink organic tea, loose leaf organic tea every day with my water, drink a lot of water, have coffee in the mornings, dairy-free creamer. I just built a greenhouse, so I try to eat all greens. I'm very strict on my diet. I do a lot of exercising. Um,
That's where I was going with this.
yeah,
That's where I was going.
and some days I have to fight through because I get tired very easy. So that I do a lot of swimming. During the winter months, I do a lot of jogging. Yeah.
I was, Dr. Lloyd, I think you and I are both aware of some new research that has come out that has actually talked about the benefits of inspiratory muscle strength training to building the strength and stamina in the voice. And so I think you're getting at that with the swimming, because there's no better
Awesome.
no
It
better
helps me so much.
exercise for lung capacity than swimming. So, and there's also some devices that really target that inspiratory training and the exercise. So yay, good for you.
Yes, I'm working all the time. It's a battle. It is a battle every day, some days more. I do worse during the winter because I have Raynaud's really bad. So I have to fight. I get cold really, really easy, even during the summer. When I get out of the pool every day, I immediately put my clothes back on because I'm so cold.
Yeah.
And also on Sunday mornings, if I'm cold, that interferes. After I've been warming up, I'm thinking, what did I warm up for? I'm cold again. But it does help. So yeah, it's a battle, but
Wishing you the best.
I'm willing to fight. So I'm a fighter, I guess.
All right. I think, are we out of time, Elizabeth? I think we are, right?
Yeah, we do need to
Okay.
wrap up. This has been amazing though. So please take a moment to wrap up for yourselves.
Okay, awesome. Well, these are our email addresses here. Thank you again, for having us tonight. It's a pleasure. I just want to say that, one of the highlights of my career so far has been collaborating on doing clinical research. And Stephannie and I have been collaborating for many years on a longitudinal study and, hopefully some other studies in the future. And as a result of our collaborations, this has led to doctoral students in the School of Music wanting to learn about more about research and doing small projects. So it's been a really rewarding part of my career, and that has come out of our collaborations. So thank you so much again.
Absolutely. Thank you so much for having us. It was a pleasure. Excited to kick off your season.
Yes.
And please feel free to reach out if anyone has any other questions.
I was going to say, we may have time for just a quick question if there was anyone just itching to ask anything, but I'm not seeing any movement. So I do want to thank the two of you again for, I have lots of notebooks of notes over here, and lots of things to go look up and research and read. And thank you just so much for the personal touch and everything. It was a wonderful meeting.
Thank you so much. Thanks for having us.
Thank you. And hi, Audrey. Look at Audrey is here thanking us, Adam, who worked with us.
Oh, Audrey.
Oh, great.
Awesome.
Well, thank you all so much, and have a wonderful evening and season.
Yes.
Well, thank you. Well, we want to thank the two of you, and if anyone has any questions, you can reach out to their email. You can also reach out to us at our email or through our social media, and if you'd like to be added to any future communications. But for those of you who are here and members of the Alabama Voice Foundation, we'd like you to think on future membership and our future meetings. So thank you so much.
Have a good night. Happy fall.
Happy fall.